Good morning, folks. Thank you for being here early. Please familiarize yourselves with the controls of this live webinar, and we'll be with you right around 10:30. Thank you. Good morning. I'm your host, Lenny Orlov, with Seattle Human Services. If you're joining us online, live or on YouTube, we invite you to explore the closed captioning options of this video by clicking on the gear under the video and selecting one of 7 languages: Arabic, Chinese, English, Korean, Russian, Spanish, or Vietnamese. Our YouTube channel is called Aging King County, and if you click the subscribe button and the bell, you'll be notified when our next video is uploaded. Before we begin today's program, I would like to ask everyone to join me in our land acknowledgement. November is National Native American Heritage Month. This month and every month, we want to acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present. We honor with gratitude the land itself and the Duwamish tribe. Visit duwamishtribe.org to learn more. Find out how to get involved, including their upcoming events. This is our first time together in November, so here's a quick primer on what age-friendly Seattle virtual events have to offer. This programming is one of the ways to help older adults stay safely connected to and informed about community and government resources during the COVID-19 pandemic. In 2020, we're live with Close to Home or the Civic Coffee Hour every Thursday at 10:30 a.m. Pacific Time, except for the fifth Thursday of the month, and major holidays, like this month on Thanksgiving Day. Our special non-Thursday event this month is the African American Caregiver Forum on Saturday, November 14th from noon until 2 p.m. Next week on Close to Home, we welcome Sarah Sisko and Jim Boland from a local nonprofit called HopeLink. They will talk about mobility and employment services their organization provides. This one and all of our other online programs are accessible from the same virtual event hub, bit.ly/age-friendly-live. No spaces, but each word is capitalized. Visit there anytime to find information on upcoming events and a playlist with all the previous episodes, also with subtitles in these 7 languages. But now I'd like to welcome you to today's program. Unlike the previous 19 episodes of Close to Home, Stories of Health Tech and Resilience, today we only have one guest. But in addition to a presentation, Dr. deMaine will treat us to a mini book reading. He will have a total of about 20 minutes, followed by a 10-minute question and answer period based on the input provided by the live audience, online or on the phone. So get your comments ready and type them in right away, even while Dr. deMaine is still speaking. My City of Seattle colleagues, Karen Winston and Tara Shively, will gather all of your input and pass it along to our guest, who will either respond on the live broadcast or in a YouTube comment once the video is uploaded. You'll also get his contact information in case you wanted to reach out directly. And with any questions related to aging or disability, please call 1-844-348-5464 and speak to a Community Living Connections advocate. They can help locate a wide range of resources, including food and meals. The call is free, interpretation is available upon request, and services offered are professional, confidential, and most are also free of charge. Again, that number is 1-844-348-5464. You may also visit them on the web at communitylivingconnections.org to see the list of participating organizations in the network with the links to their individual websites. Again, communitylivingconnections.org. Lastly, here's a resource that's there to help all of us navigate the COVID-19 pandemic. According to coronavirus.wa.gov, Washington State's coronavirus response website, staying home is still safest, with an emphasis on restricting gatherings. To prevent virus transmission and move us closer to a successful safe start, we're encouraged to stay as close to home as possible. But when we do go out, we're asked to keep it quick, maintain social distancing, and wear a facial covering. This information is currently offered in all of 36 languages. Pretty impressive. But the take-home message here is fewer, shorter, smaller, safer. Other information such as what's open, where to get help, and how to report a violation is also available on this website, coronavirus.wa.gov. Please tell your loved ones about this online resource and also about Washington Department of Health Assistant Hotline. We're all invited to call 1-800-525-0127 from 6 a.m. to 10 p.m. Monday through Friday, and from 8 a.m. to 6 p.m. on Saturday and Sunday, and on any observed state holidays. Again, 1-800-525-0127. Or if you just want to talk about the stress related to COVID-19, please call Washington Listens at 1-833-681-0211. That number is available Monday through Friday, 9 a.m. to 9 p.m. and on weekends from 9 a.m. to 6 p.m. The number for Washington Listens is again 1-833-681-0211. So now it's my pleasure to introduce Dr. Jim deMaine, MD, author of a new book, Facing Death, Finding Dignity, Hope, and Healing at the End, a memoir about helping patients plan for a more peaceful, healing death. Among other things, it explores the role of spirituality, conflicts between doctors and families, and cultural traditions. Dr. deMaine was the chief of medical specialties and co-chaired the ethics committee at Group Health Cooperative, which is now Kaiser Permanente. He is honored to be a clinical professor of medicine emeritus at the University of Washington School of Medicine. His often dramatic experiences with patients near death led him to blog, then speak about their stories, with special attention to the issue of advocacy for patients unable to speak for themselves. Now, about 2.5 years ago, which was less than a month into my City of Seattle tenure, I remember helping out with audio equipment for one of Dr. deMaine's talks at Seattle's Central Area Senior Center. So today, I'm very happy to again play that role and pass the virtual microphone over to him. Dr. deMaine, thank you so much for being here today. Please remember to unmute. You are live on Close to Home.
Okay, can you hear me okay?
Yes, we can.
Thank you very much, Lenny, for that nice introduction, and thank you for all of you that may be willing to listen to a conversation about death and dying. Lenny mentioned the COVID epidemic. I think that subject has brought death closer to home to all of us, and it's a subject I think in our society that we've neglected to talk about in the past, but the inevitable will happen. We're not going to escape this, and that someday we will all face our final breath. But in my practice in pulmonary critical care medicine, I dealt with death and dying a lot, and the most effective way I found talking to people and families in crisis was to tell stories. And people would often listen and gain more than just trying to give facts or options. So my book is a book of stories, and I'd like to go ahead and tell you one that, without reading it, about Larry. He was a 75-year-old man who had, unfortunately, severe bronchitis and emphysema, basically COPD. He had had multiple hospitalizations for this. He was having more and more trouble breathing. He now needed to use oxygen all the time. And he surprised me in the clinic one day. He said, "Hey, doc, I want to take you out to lunch." And Larry was a super salesman, kind of a crusty kind of guy. We were pretty friendly together, but I was worried that he was going to try to sell me something. And the way he was trying to talk to me about his end of life and what his wishes were. So after pleasantries over lunch, he looked at me and said, "I want you to help me die." And that was before we had any options like the death with dignity laws. So I explored that with him. And he said that his quality of life was terrible. He was unable to do any of the things he wanted to do anymore. He was living alone. He didn't want to get help in. He didn't want to go move in with his family. And he was really worried. He'd had multiple hospitalizations where he said he couldn't breathe. He said, "I'm like a fish out of water." So I said, well, there are things we can do at the end that are permissible and would relieve your suffering. And he said, "What's that?" And I said, well, the best drug for people that can't breathe and are near the end of their life is morphine. We can give small doses. And he said, well, what does that do? And I said, well, it gives you euphoria, a sense of well-being. It makes you sleepy. It takes your shortness of breath away and makes you much more peaceful. And he said, well, that's what I want. But I said, there's a downside to that you can have a bit of a shorter life. These drugs can shorten your life by a matter of hours or even days. And he said, I'm not worried about that. I just don't want to be like a fish out of water and gasping for breath at the end. So I said, Larry, talk to your two sons and let's reconvene in a month or so. And they did, and the son supported his wishes. I also discussed it with a few colleagues and a theologian and looked at the medical literature. And it is permissible to give sedatives at the end if the intent is to relieve suffering. The intent wasn't to end his life, but the intent was to relieve suffering. This is called the double effect. Obviously, some people might want to split hairs and say that I'm euthanizing him or he's committing suicide. But in reality, if we can aggressive treat symptoms, if you're suffering with pain or shortness of breath, that's what a lot of people would want. And that's eventually what happened. It went, you can go back to full screen, but it went to the point that he was not doing well. I was at dinner one night and got a call from the emergency room, and he said that he was, well, the emergency room doctor said, I've got this guy here, he can't breathe, I need to put him in an intensive care unit, but he wants me to call you. And I said, I don't think he wants to go into intensive care. Have him held there and I'll come in. So I went into the emergency room and there was Larry kind of gasping, but he was awake enough and he looked me in the eye and he said, remember what we talked about? And I said, okay. And I reviewed the plan with him and we did not admit him to the intensive care unit. In the ICU, he could be put on a ventilator, we could do CPR, we could do shocks. There's a lot of things that we can do, but he didn't want that. And up on the medical ward, I had two senior nurses that were comfortable giving him small amounts of morphine periodically to basically titrate his shortness of breath. And he became sleepy and peaceful. His sons were there, and he died at about 3 in the morning. So I got a letter later from his sons saying, Dad got the kind of death that he wanted. If he could come back, he would shake your hand. He died in a peaceful way, in the way he wanted. So I'll read a little bit more about that. In this book, I present my own stories, lessons learned from patients like Larry and many others who taught me about dying. My medical career began in an era when little could be done for two of our greatest killers, heart disease and cancer. There were no ventilators. I often saw patients die without the benefit of hospice cares. ICU and CCU had not yet evolved. But with amazing rapidity, medical science has brought us life-saving advances such as hemodialysis and organ transplants. This progress is both marvelous and problematic as technology continually outpaces our ability to thoughtfully and ethically bring it to the bedside. When should life-prolonging advances be used? How do we decide how to allocate these tools when resources are scarce or prohibitively expensive? My stories are about hopes and fears common to us all. They are about the ethical dilemmas I've encountered and moments that have humbled me. They address advanced care planning, medical aid in dying, conflicts, medical mistakes, modern hospice, and palliative care. They can be read in the order presented or topically as relevant to each person's immediate questions and concerns. In the last section, I share my thoughts about resilience, spirituality, and leaving a legacy to our loved ones. As I wrote about these patients and my experiences with them, memories surged to the surface of my thoughts, often bringing up deeply rooted feelings of sadness and joy, even fear. Did I do the right thing? Was I losing empathy? I hope as you read the stories that they encourage you to talk to your loved ones about your own hopes and fears. My greatest wish is to generate some much needed conversation about the inevitable and the choices we must consider. There is no easy way to put it. To ensure our autonomy is respected, each of us must choose our path at the end. So I'd like to read you another story and then show you a few slides. But this story is about a very lovely lady who had a very serious medical problem. And initially I didn't really support, or I didn't particularly like the path that she was choosing, but ultimately I went along and she taught me a lesson, basically. Marie was too young to have a terminal diagnosis. She had primary pulmonary hypertension. This condition is called primary because we have no idea of the cause. Medical lingo has taught us a variety of ways to label unknown causes, such as idiopathic or essential. In Marie's case, the word was primary, though none of these labels convey any level of deeper understanding. In any event, primary pulmonary hypertension is a devastating diagnosis that affects adult women about 3 times more than men. Marie was a soft-spoken woman of Asian descent who had been born in Guam but lived in the US for many years. She raised 3 children and helped her husband's business as a bookkeeper. She had a beautiful smile and tended to downplay her symptoms. Her family physician had referred her to me for puzzling shortness of breath. We ruled out causes like fen-phen or blood clots and began drug treatment to try to dilate the vessels going to her lungs. Essentially, all the blood returning to the heart from the rest of the body needs to be pumped out to the lungs, where it gives off carbon dioxide and picks up oxygen. It's normally a low pressure system, but not in Marie's case. Over the next few years, she began to fail. We tried other drugs and even a battery-powered continuous IV medication in addition to oxygen treatment. In the midst of all this, Marie decided to make her annual trip to Guam, where many of her relatives still lived. I wanted to make sure she was stable enough to travel, so I reached out. Marie, how are you doing? Oh, fine, doctor, a little limited, but I can't complain. I asked her to come in. On examination, it was clear that her condition had grown much worse. Marie was short of breath, her oxygen levels were lower, and her legs were swollen. We needed to consider more drastic measures. Marie, your condition is becoming life-threatening. The drugs are not working and your cardiac echo is showing very high pulmonary artery pressure. I'd like to refer you to the University Hospital to consider the possibility of a lung transplant. Oh, doctor, I would never want anything like that. Why not? I'm at peace with God, Marie said. What will be, will be. I don't expect miracles, and surgery seems too risky to me. I think I'd rather just go on. I asked Marie to bring in her husband, Gerald. He was seldom in the exam room with her, and I wanted to make sure he understood the seriousness of Marie's situation. She smiled at him when I brought up lung transplantation. Gerald smiled back. Look, doctor, we've already talked about this, Gerald said. Marie doesn't want surgery. She knows her time is short, and we're flying back to Guam next week. We'll be there a month. I began to understand something important. Marie and her husband were further along in accepting impending death than I was. As Catholics of strong faith, they had a kind of fatalism that I didn't often see in my practice. They had accepted Marie's fate, while I was still ready to fight on. I okayed her for oxygen use on the airline. Marie arranged for additional oxygen in Guam. During the month she was there, I received a postcard saying, "Don't worry, I'm okay." But upon her return to Seattle, Marie was much worse. She had episodes of severe shortness of breath, could no longer walk across the room, and was becoming bedbound. Marie and Gerald agreed to a hospice referral. From that point on, I received regular updates from the hospice nurses who were helping Marie be comfortable with small doses of morphine. After a few months of home care, the hospital nurse called. Dr. deMaine, we're wondering if you could visit Marie at home. She and the family would like to see you. I didn't quite know what to expect when I left the office at 6 p.m. to stop by their home in a pleasant suburban neighborhood. A child shyly answered the door and called for her grandpa Gerald. Inside, the scene was surprisingly festive. Large dishes of food crowded the dining room table. There was music on and kids running, playing. In the midst of it all lay Marie in her hospital bed, her head propped up so she could see all the activity. A sleepy smile crossed her face as I walked into the room. Why don't you get something to eat, doctor? You must be tired and hungry. Marie was taking care of me. I sat with her for a while, listened to her chest with my stethoscope, and held her hand. The warmth and love surrounding Marie and her family were palpable. I felt tremendous respect for her emotional strength in facing death. Within a week, Marie was gone from this life, but she'd left behind a beautiful legacy of love and acceptance. This was a blessing for her family and for me too, a healing. I came away moved and inspired, hoping that I could someday face my own death with such equanimity. And then when it happened, I would have my loved ones close by. Marie's family had listened to her, and they were able to give her wonderfully caring support. So at this point, I would like to end the readings, although obviously there are other portions of the book I'd love to read to you. But I'd like to go through a few of the PowerPoint slides. Lenny, they're visible? Okay. There's an author named Rowan Soroyan that says everybody's got to die, but I've always believed an exception would be made in my case. And that usually gets a few laughs out of an audience. But it's true, we go about our daily lives not thinking about death and dying. In this sense, denial is good. We can go on with our lives and seek out love and happiness and usefulness as to whatever path we follow. But unfortunately, the inevitable does happen, and it's something we have to face up to. And the next, please. This is a slide from a humor magazine called The Onion, and it just notes that world mortality remains 100%. So it is going to happen, and I don't think I need to update the slide because we know inside, deep down, that we're not going to live in this world forever. Next slide, please, Lenny. In the book, I go through 3 pathways of care, but a message I like to leave to everybody is that it's so important to start with a conversation. And I'll get to some resources at the end, but if you want to go to just one website, it's just called Prepare for Your Care. If you just type in Google Prepare for Your Care, you'll find this website. And it's got all the forms you need, and it's got explanations, videos, and a lot of help getting started with the conversation. A lot of families are reluctant to discuss death and dying, but it's really a gift for older people if they can talk to their children about quality of life, what would be acceptable. For example, if I developed dementia and I was in a nursing home for a couple of years and I was not communicating with anybody anymore, and suddenly I had a urinary infection and a temperature of 104, personally, I don't think I'd want to take an antibiotic. I would just like to let nature take its course. And I certainly wouldn't want a tube feeding or CPR. Those are the kind of things that we can talk about and have that conversation. After the conversation, and I plead for this in the book also, is find an advocate, somebody that's close to your heart, because in the last 2 weeks of life, we can't really often express our own wishes because we're too sick. We could have a stroke, we could be unconscious, we could be critically ill. So our durable power of attorney, our loved one, somebody who's close to our heart, has to take on that responsibility. And it's a huge responsibility. And without a conversation, they're only going to be guessing. They're not going to be knowing for sure. So having that conversation is so important. And then beyond that, you can fill out your advance directives as they are listed and prepare for your care. And in general, there's 3 general pathways we can consider for our care toward the end. One that unless you have a form that indicates otherwise, we are all signed up for life prolonging care. Society rightly values life. So if we fall down at Costco or Safeco Stadium, the stranger can begin CPR, can bare our chest, apply shocks with an automated electronic defibrillator. So these are the default for all of us, unless we have a paperwork or we have a durable power of attorney that says otherwise. Now, some people will say, you know, I'm 90 years old now. I really don't want heroics, but I would want some selective medical care. I would certainly want antibiotics. If I had a short-term medical illness like a pneumonia or let's say COVID, I might be willing to go on a respirator for a week or 2, but if it looks hopeless, please turn it off. Those are the kind of things where you need to have conversation about the options and understand the options. The last level of care, and I do talk about this quite a bit in the book, is about hospice and palliative care. Palliative care is a new specialty in medicine. There's a wonderful training program at the University of Washington, the Cambia Center of Excellence for Palliative Care. And they are physicians that look at the big picture in a holistic way. They don't focus just on one set of organs. They look at you and your suffering and try to address that. It could be pain, it could be shortness of breath, it could be conflicting messages that you're getting from specialty. But palliative care consultation can be called in when it's a confusing or difficult situation. They mostly operate in hospitals, but they're also outpatient consultations. Hospice, of course, is a government-funded service or private insurance companies often offer it. And this is through Medicare. After age 65, we all qualify for hospice care, and it provides a lot of added medical benefits. These are people that have decided they only want comfort care. They would prefer not to be transferred to the hospital. They would like to die at home or in a home-like environment, and hospice can step in and help arrange all of that. And there are considerable cost benefits like medications and durable medical equipment, training of caregivers and spiritual help as well. So let's look at the next slide, Lenny. So this is the cover of the book, what it looks like. It's certainly available at bookstores like Elliott Bay Bookstores and other bookstores in town, and also available online at Amazon. If you're thinking about this subject, this is one way to start. There are a lot of books and pamphlets out there, but I still feel one of the best ways to learn is through stories. And that's really what this book is. Each story kind of has a lesson that goes with it, but it is stories, and I think fairly easy to read and not too long. So next slide, Lenny. So the resources, basically I have a blog, endoflifeblog.com, and a Twitter. I put notices of talks and other thoughts up there. This is the website I mentioned that has advanced directive forms, prepare for your care, and a lot of other information. And I think, as Lenny mentioned, there's a town hall event coming up on November 16th where I'm being interviewed there by Katie Sewell. And there's a link that you can click on. Again, I'll be discussing the book in more depth and the whole subject. The book sponsor for that is Elliott Bay Books, and End of Life Washington is also a sponsor for that event. So I think that can conclude my remarks, and Lenny, we can probably field questions if any have come in.
Thank you so much, Dr. deMaine, for the reading and for the resources. I am going to check on the phones and see if folks have any questions or comments there. But in the meantime, this is a great time to go ahead and type your questions there in the live Q&A so that one of our moderators could then read it on the air for Dr. deMaine to answer. So at this point, let's go to our phone participants. Only just 1 second to get those lines open. All right. So you are now live on Close to Home. You may need to unmute your line by dialing *6. But if you have a question or a comment, please let us know. All right. Well, thank you for joining us on the phone today. Let us then go over to Karen Winston, who I believe has at least one question there in the queue for Dr. deMaine. Here we go.
Thank you, Lenny. We have a couple of questions here. The first one, what is the best way to start a conversation about end of life with my adult children? They tend to make fun of the notion, so I know they are not comfortable about talking about it, excuse me.
You know, that's a great question, and there's a lot of families that face exactly that. There is another website I might recommend that really helps with the starter issue, and it's called the Conversation Project. Ellen Goodman, the Pulitzer Prize-winning author, her mother did not have a good death, and they did not have conversations ahead of time. So she's brought together a lot of experts that talk about the starter conversation, how to break the ice. Sometimes if there's so I would definitely go there and look at the starter. They have a starter kit actually that you can go through. There's card games that they can play. For some people that are just looking for more information, they can join a death cafe. They're online meetup groups where people talk about death. But in terms of talking to the family, I found it kind of effective if there's been a death of a grandma or a neighbor or an unexpected death or a suicide or something like that, or or the difficulty that's going on with COVID patients, where it's kind of unknown whether they want to go on a ventilator or not when they're so sick. So, that's a way to start the conversation, is not talk directly about yourself, but talk about others. And I found that true in the intensive care unit when I had a family at a standstill. I would say, gosh, I had a patient just like your mom that was here a week or two ago. And then we walked through that whole scenario, and that then got them back on track so we could talk about the situation at hand.
Okay, thank you. We have another question. I hear conflicting advice about POLST forms. Should everybody have one?
Okay, the POLST form it stands for Physician Orders for Life-Sustaining Treatment. It's what I call a 911 form, because it's bright green, yucky color. It's very visible if 911 arrives. And it's most useful for people that want limited care or comfort care. Let's say you have advanced cancer and you're on hospice care. I think universally the POLST form is very useful there, because it will tell Medic 1 more often than not that you do not want resuscitation. You might say, I do want an antibiotic, or I do want maybe even a short period on a ventilator. But when 911 comes crashing into your apartment or your home, and you can hand them this form and it says do not resuscitate, they're very relieved, because they don't want to resuscitate people that have advanced cancer and are at the point of death. For some seniors, when they become frail in their late 80s or 90s or even earlier, are just saying, I don't want to risk having CPR, cardiopulmonary resuscitation, I don't want heart shocks. And that can be listed right on top of the form, and it needs to be visible somewhere in your apartment or home. Most people put it on their refrigerator. Some retirement communities, like the one I live in, have a standardized place to put the POLST form on the inside of the kitchen sink door. There's a hanging folder that I have people put their medications, their prior diagnoses, and their POLST form. It's not truly necessary to have a POLST form if you want everything done, because the default for the medics are to do everything. And I've seen some sad situations where people dying from cancer had not yet filled out their POLST form and got the full bore treatment and brought into the emergency room. And there's a story in the book about somebody that was allowed to die in an emergency room that ran into that situation. In some areas of the country, it's called the MOLST form, Medical Orders for Life-Sustaining Treatment. But I think that, I've one filled out for my wife, and I each have one filled out, because, we're getting older now and more frail, and having questions about whether we would really want, life-sustaining treatment. The thing is, most people don't understand the statistics of cardiopulmonary resuscitation. Let's say you're 50 years old and you have a heart attack and you have an arrhythmia, and the medics come and they find that you have a shockable rhythm. In other words, there's enough heart activity that could shock it back into normal. The survival rate in that younger, relatively healthy age group is as high in King County, as high as 50%, which is shockingly good compared to the rest of the country. And Morley Safer came out to Seattle years ago and said Seattle is the best place in the country to have a heart attack. It's on 60 Minutes, and it's still available on YouTube. But in terms of whether a senior really wants that or not, their outcome is, if you're very frail, let's say you're 90 years old and you have a heart attack, your chances of getting through that are about 1 in 20. it's about 5%. And even then you can come out with some brain defects or spend the rest of your life in a nursing home. So it depends how frail you are and how comfortable you are with your own dying process. Some people say, hey, no matter what, keep doing everything. I mean, that's their choice. But the problem with technology is doctors can always find one more treatment or one more thing to do to try to keep you alive. And we hope to only die once. You know, you don't want to die every day in the intensive care unit while you're getting advanced technology in kind of a fruitless way.
Okay, and our last question is from Robin. My best friend has been battling pancreatic cancer for over 2 years and is failing fast now, in my eyes. I'm very willing to chat with her about death-related issues and try to bring up things in everyday conversations. I don't know that she has these discussions with her family. I don't know what to ask you except what should I bring up that I wouldn't have already as a best friend?
You know, having somebody really close to your heart is so important, and sometimes both sides tend to not bring up the fact that the person's dying. And I think that, you know, sometimes I've said, well, do you think you're getting close to the end of your life? Are you worried? Are you thinking about that? Just, you know, fairly direct. Or you can say, have you talked to your family about what your choices would be if your heart stopped? And also you can say, you know, you're getting, depends how ill the person is, but if they have less than 6 months to live, I would really encourage them to talk to hospice. And then, you know, people have other resources. They have their church, their rabbi or their imam, people in their spiritual community that they can talk to. But we didn't used to talk about death. I was taught in medical school, never talk about it. And we didn't even mention to somebody that they had cancer. We would always whisper it to a family member. So her friend might be more willing than she thinks to have that discussion if they're really, really close friends. It's a subject that, you know, with advanced pancreatic cancer, I've had 2 or 3 friends die from that. In fact, I write about one in the book that chose the death with dignity option. But he had very advanced cancer. His gallbladder was destroyed. They had to put a tube in through the abdominal wall to drain a gallbladder. And he tried hospice, tried pain control, but he couldn't sleep, wasn't comfortable. And he was kind of a high control person. That's just the way he ran his life. And right at the end, he decided that he wanted to do death with dignity. So some people will take charge of their deaths. Some will, you know, keep putting off having a conversation. But I think with advanced pancreatic cancer, that it's really time to have the conversation. And you could be fairly direct, you know. Have you thought about how long you're going to last with this disease? Have you thought about making any plans, you know? That kind of thing.
Okay, and Robin responds, direct and choices. Thank you. Age 64, so palliative care.
Yeah, and it depends on the prognosis her doctor gives her. I had one patient with cancer that was young and had stage 4 colon cancer and kept kind of putting off and seeking more treatment, and didn't get into hospice until the last day. So another point to make in the book, if you have less than 6 months to live, it's never too soon to get established with hospice, because they'd like to get to know you. if you get better, then you can be discharged from hospice. Some people don't want to get into hospice because they think it's a death sentence, but you don't have to die within 6 months. You can live longer than that. And in fact, there's data now that show that people that get into hospice tend to live longer than people that don't, because they do get the palliative care. They get the people surrounding them, and it takes a lot of their angst away from them.
Okay.
All right. Well, thank you so much, Dr. deMaine. Sorry, Karen. I just have to do a time check because we are 1 minute past the end of our program. However, we do have some additional questions there in the Q&A. So I'm going to ask, first of all, Dr. deMaine, if you have time to answer a few more, and if folks are available. You do?
Yes, I do. Sure.
Great. If folks are, want to stick around, we'll do that, and then we'll wrap it up. So there's one question that came in a couple of ways, and that is asking you, Dr. deMaine, to speak to fear. And looks like the person has added, if there's no direction and no one in the family who, how does end-of-life determinations made, how are those end-of-life determinations made by medical providers? I think that's the other part of the question there.
Yeah, well, in terms of medical providers, they, if you have advanced pancreatic cancer, for example, the oncologists, the cancer specialists, kind of know from statistical data based on where your disease is spread and your current situation. It's an educated guess based on statistics that you have less than 6 months to live, and then they can, refer you to hospice at that point. Hospice is not really giving up. It's kind of accepting the inevitable. The other part of that was fear. Is that what you said?
That's right.
Well, that's a tough one because we're all so different about what we're afraid of. I think that in terms of our own upbringing, our experiences with death, I think the fear needs to be explored. Are you afraid of pain? Are you afraid of shortness of breath? Are you afraid of leaving loved ones behind? Are you afraid that you're not financially stable and others will be suffering? Or is it more existential, kind of what happens after death? And maybe you have some regrets that aren't resolved. When people said, how much time do you need if you really know you're going to die? And a lot of people would say about 2 weeks. Give me time to draw everything together, say I'm sorry to the people I need to say that to, make amends, leaving a legacy of some kind. There's an interesting website called GYST. I won't say it here, but it's Get Your Stuff Together. It's a woman whose husband died, and she didn't have any of his passwords, couldn't get into his cell phone, and so she had no knowledge of anything. So I think her fear was, and she's trying to help people with, is get all your ducks in a row, your estate, your websites, your accounts, everything. So that's more of the nitty-gritty of planning for the inevitable. But fear is going to be individual and has to be addressed individually, depend on what you're afraid of.
Thank you, Dr. deMaine. You all see resources here on the screen, and we've posted some of them in the live chat, and they will show up, of course, on YouTube in the description. I think we're going to move on now to the closing part of our presentation. I just wanted to say that Robin, our previous commenter, did say that this was very similar to your friend. So go ahead and publish those comments. So at this point, I would like to thank you again, Dr. deMaine, and I do hope that folks will go to endoflifeblog.com and check out Dr. deMaine's blog. It's really something that I've looked at over the years, and that I also hope that you will check out the town hall. Those links have been posted as well. Special thanks today go out to Elliott Bay Bookstore and the Mayor's Council on African American Elders. Both helped us promote this event on Facebook, so thanks for that. And thanks also to my Human Services Department colleagues, Karen and Tara, for their work in the virtual studio today. But most of all, thanks to all of you for tuning in to the live show and for checking it out on YouTube. If you haven't already, please consider joining our virtual community. You can do that, it's free, by clicking subscribe button and the notification bell. And then you'll know next time we put something out there. Before you go, I do want to remind you all about the network of community organizations supported by the City of Seattle and King County that's called Community Living Connections. You can call them with anything related to aging or disability, including end-of-life resources. Their number is 1-844-348-5464. Or you can visit them on the web at communitylivingconnections.org. Please be safe, be well, and continue to stay socially and civically engaged in your community. The November 3rd election has seen an unprecedented number of ballots cast here in Washington and around the United States. And 2 days later, the uncertainty of not knowing many of the results may really bring about a range of emotions for some of us. But we know that democracy takes time and that these feelings are real. So we do encourage you to reach out to Community Living Connections, to Washington Listens, or connect with a friend or loved one. And of course, we'll look forward to seeing you and them at next week's Close to Home or at another Age-Friendly Seattle virtual event. Take good care, everybody.